Hi, my name's Lauren, and this is Feeling Capable, an overview of capacity assessment for junior doctors. So I'm going to begin by talking a little bit about what capacity is. So capacity, as defined by the AWI Act, is the ability to understand information, to retain it and use it, and to communicate a decision about treatment. It is specific to time, so it varies from time to time, and it is task specific, so you can have differing capacity based on the task that you are required to do. So I'd also like to say a word on what capacity isn't. So it absolutely is not the ability to make what you feel to be a sensible decision. You or I are perfectly able to make decisions that are not sensible, that are not wise. That's a picture of me in the bottom right making a terrible decision. And so is anybody else who has capacity. It is not static, so we mentioned before that capacity is time specific, so it varies from time to time, and it's not global. You can't say that just because somebody can't make one decision, they're not able to make any decisions. Something else that's important to remember is that you cannot base your assessment of capacity on assumptions about a person's medical or social history, so you can't read their notes and make a decision about their capacity. This is something you need to assess in person and on a person-to-person basis. So we've been talking about capacity, and the question now is who does these assessments? Who is it that assesses capacity? And the answer, of course, is that you do. So it's a common misconception that psychiatrists do all of the capacity assessments. They can be helpful in complex cases or cases where there's disagreements about a patient's capacity, but they will not routinely do assessments for you, and they certainly won't thank you for phoning them for routine assessments. So all doctors with full registration are qualified to make capacity assessment, and anybody who works in healthcare should be considering their patient's capacity to consent to treatment or interventions at all times. And the principles of capacity assessment that I really want you to take home with you to remember, even if you learn nothing else from this presentation, is first of all that we must presume capacity unless proven otherwise. So every patient you meet, you should assume they have the capacity to make decisions unless you have a really good reason to think otherwise. And the second principle is that we must be doing everything we can to maximise our patients' decision-making ability. So you should be making a positive effort to help your patients to make decisions for themselves wherever possible. And there's a really nice quotation from the GMC at the bottom there that summarises pretty much everything that we've spoken about so far. Now let's use these principles to have a look at a few case studies. You can pause the video here to read the case study in your own time, and when you're ready you can press play again to move on to some multiple choice questions. And again, feel free to pause the video and have a think. If you're thinking about everything we've already discussed, of course you're going to just give him his hearing aids, which you do, and he can hear you fine, and you have a very lucid conversation, after which he of course tells you that he doesn't want to go to a nursing home, he wants to go back to his own home. And as we mentioned earlier, people who have capacity can make decisions for themselves, even if we as healthcare professionals do not agree with the decisions that they're making. So let's think again about maximising decision-making ability. What can we do for patients like Jerry to make sure he is best able to make decisions for himself about his care? So make sure, first of all, that your patient is able to see you and hear you when you're speaking to them. So if they use glasses or they use hearing aids, make sure that they have these to hand. You can offer information in a written format or as a diagram if they find this easier to digest. And for patients who have complex communication needs, remember that input from our speech and language colleagues can be really helpful. If your patient doesn't speak English as a first language, make sure that you're using an interpreter when you're speaking to them. And remember also that this should really be a professional interpreter through something like Language Line, rather than just asking a family member or a friend to interpret. And remember also that medical jargon can be really difficult for patients to understand, so if you simplify the language that you're using when you're speaking to a patient, they're much more likely to understand you and to be able to use the information you're giving them to make an informed decision for themselves. Now let's move on to another case study, and again feel free to pause the video to read through the paragraph and to read through your multiple choice options, and then you can press play again when you've finished. So the most appropriate thing to do would be to have the discussion again with her and to have some family members present for support, and so that she's not having to rely on herself to remember all of the information. And what you can do is you can write down the important points so that she can look over it again in her own time, and she can use it in this way to make the decision for herself. And there she is with her yellow book full of the information that you've written down for her, having a think in her lovely garden. So thinking now about patients like Eileen who maybe have a bit of memory impairment, what are the things we can do to maximise their ability to make decisions? So you can speak to people who know the patient well and ask if there are times of day that are better for them for having conversations and for retaining information. People may get tired towards the end of the day, or if we're talking about me, I'm not a morning person. You can revisit conversations multiple times if you have to, or you can write down information like we did for Eileen there, and you can have discussions with family members or next of kin present, and this can be reassuring, it can be supportive, but it also means that somebody else is remembering the information that you're giving. And make sure that you're eliminating barriers to your patient understanding you. So if they're distracted or they're in pain, it's a lot more difficult to retain information. And remember that even if somebody isn't remembering the conversation, say you come back the next day and they don't remember discussing something with you, if they're coming to the same decision every time you're asking them to make it, then they may still retain the capacity to make this decision for themselves. And again, you can pause the video to consider our third case study. And of course, the most appropriate thing to do would be to wait till the morning and reassess Mr. Patience then, or I suppose more accurately, ask the morning team to reassess Mr. Patience then and see if he's feeling more like his usual self. And if he is, we can try discussing the staging CT with him at that time. Let's think about decision-making in the context of delirium then. So it's relevant to remember that capacity is time-specific, so it can fluctuate from day to day or from hour to hour, and you need to be assessing your patient's capacity to make a decision at the time that decision is relevant and needs to be made. So if it's feasible to delay the decision-making until the person's feeling better and is more able to do this for themselves, that is what you should be doing. It's important to remember that autonomy is one of your 4 pillars of medical ethics, so it's no small matter to be taking away somebody's ability to decide on their treatment for themselves. So as much as possible, you need to be preserving a person's ability to do this for themselves. And I have a final case study for you here, so again, pause the video and have a think, and then press play when you're ready. And of course, the most appropriate thing to do is to think about all of the elements of your proposed management plan for her separately and to assess her capacity separately in relation to each of these. And you only need to fill out an AWI form, and you only should be filling out an AWI form if she lacks the capacity to consent to any of these aspects of her management. And of course, she's there with her thumbs up because you've been a considerate doctor and she appreciates that. And as we have been doing, let's think again about maximising decision-making ability. So remember I said at the start of this that capacity is task-specific, it's not a global thing. And you can consider simple versus complex decisions. So somebody might be able to decide, for example, what they want for breakfast, but they may not be able to decide whether they will be discharged home or into long-term care. And your treatment plan, as you fill it out in the back of your AWI, should be specific to the patient. You shouldn't be using a generic treatment plan. And you should be assessing your patient's capacity separately for each item that you're writing on that treatment plan. So what do I mean by this? How do you make your treatment plan specific to your patient? The most important thing is that you must be making an active effort to find out what your patient would have wanted for their treatment when they retained capacity. And you can do this in several ways, and probably the most important one is to speak to people who know the patient well. So if they have a legal power of attorney, you must make an effort to contact them. And you can also speak to their next of kin or with carers, anybody who knows the patient really well. You can look on the computer system as well. You can check if they have a GP key information summary or an anticipatory care plan, because there can be a lot of really useful information in here. Make sure you're looking back in the medical notes as well, because these things may have been discussed before and documented, and this can be a really useful resource. And when you're considering any proposed intervention, remember the principles of the AWI Act. So anything that you propose must be the least restrictive option to the patient, and it must have a clear benefit as well. We shouldn't be doing anything just for the sake of it. And of course, it goes without saying that you should make sure that you're documenting any discussions you have, because anybody coming after you needs to be able to see what decisions have been made and what discussions have happened already. We're coming to the end of this video, so here's a list of the key learning points that I want you to remember and to bring forward into your clinical practice. So first and foremost, remember that patients should be presumed to have capacity. You should be assuming that everyone you meet can make decisions for themselves unless you have a really good reason to think otherwise. And remember that it's your responsibility and your obligation to maximise your patient's decision-making ability, and we've discussed a few important ways that you can do this. Remember that capacity can be variable, and remember that it is specific to the time that you're seeing the patient and the task that they're required to do. And remember finally that Section 47 treatment plans should be specific to the patient in front of you, and you should be speaking to patients' relatives and their powers of attorney, next of kin, and using other information sources to try and determine what a patient's wishes would have been when they retained capacity. Thank you for watching, and thank you for listening.